Welcome to part 2 of our 2-part podcast series, CRST the Podcast, Telehealth in Ophthalmology, Hip or Hype. We're glad you've joined us to hear Drs. Habash, McCabe, Williamson, and Zaldivar conclude their conversation. This program was supported with advertising by Novartis Pharmaceuticals Corporation. The opinions and views expressed during this program are those of the individual participants and are not necessarily those of Novartis Pharmaceuticals Corporation or its affiliates. Now, let's get back to the panel.
So, I wanted to move forward a little bit here. There we go. To second opinion consults. So, the four of us and our institutions and our practices do a lot of second opinions. Here at Bascom, we have patients coming from all over the world to see us, I'm sure, just like you guys do. And now that the telehealth rules are relaxed, we are able to see patients across state lines too. So that opens up a whole new revenue model for us and for everyone out there. And that's to do second opinion consults, which are actually super easy for us because ophthalmology is an image-heavy field. So if a patient signs up for this second opinion consult, they can send medical records, you can review them, and then you do a video call. You can either charge a flat fee if there's no insurance, or you can do you can bill it as a telehealth visit based on time. And that's time spent reviewing the records, talking to the patient, and doing your care coordination afterwards. So this is me doing a telemedicine visit, second opinion consult with Dr. Flynn. I got Dr. Flynn on there, and he was in North Carolina and really enjoyed weighing in on this macular hole. But this was a very, we do this, I think I just want to say this, we do this a million times a day anyway. But this now becomes another way for patients to get another opinion, to get, to save themselves from a second visit. It just takes, it's a very quick kind of thing. But I want you guys to weigh in on that and let me know what your thoughts are.
I think we've always done these for free.
Yeah.
And they're not insignificant amount of time. I mean, I guarantee all of us have had patients who come in and they're like almost can't even lift this chart that they're bringing in with them, of stack of papers. Sometimes they'll sit there thinking you're going to actually read them right at that moment and go through them all with you. So, and it's not an insignificant amount of time to actually really understand and dive into it. And I think it's really helpful that you understand that you're going to get paid for that, because otherwise, if it's just a surprise in the middle of a visit and you have a full clinic, you don't always have the time to spend at that moment to really give it adequate attention. So yeah, I think it's great. I'm glad we have this option now.
Great.
I love it. And it opens a whole new era of new applications of digital health and different things that you know a lot, Ranya, and you have been always involved. But I think that collaborative care is something that is here to stay. And I envision in a couple of years, many of us working together in different platforms, sharing profits for different opinions, for addressing cases. For example, what Blake had just asked, what about this ICL? We can see the patient, we can analyze it, we can size the lens together, and we can split sometimes or split just a little bit of the revenue. I do think that that's the way we are going to work in the near future.
What a benefit to patients and to each of us and to our colleagues who we can more effectively learn from. I think there's just a win-win-win in every way with this.
I totally agree. One of the other visits that we had done is I had a patient I think she was from the Bahamas, and because of the travel restrictions, she couldn't come in. So she asked me to do a second opinion consult with her ophthalmologist in the Bahamas. So it was a uveitis patient. She had chronic uveitis for a while. Lots of treatments had been attempted before. So I said, well, I'm not the world's expert on uveitis. We should probably get Janet Davis involved. So ended up doing a 4-way consult with the patient, with her physician, her ophthalmologist in the Bahamas, and with Dr. Davis, all virtually, where we reviewed her records and had a 4-way discussion, and kind of gave the ophthalmologist there on the ground the tools with which to treat the patient. So, I mean, I think that kind of thing is just invaluable. Where I like what you said, Roger. I mean, this is collaborative care, you know, and this is how the future should be, where we're just helping patients together, and giving ophthalmologists anywhere in the world access to our expertise.
Even prior to COVID, you wouldn't have the resources to bring together that level of expertise for a patient.
Yeah, I think that surgeons who are working at very renowned institutions and universities probably could use this a heck of a lot more, or be very busy using this because that's what patients know. You know, patients just Google around and see, BP, for instance, #1 in the world, and so naturally, if I was a patient, I'd say, well, geez, if I could remote in, why wouldn't I get an opinion there? I think in the private practice setting, specifically a high volume, refractive cataract practice like mine, I think the key with this is that you'd have to kind of almost set aside time to do your consults, right? So I don't know that I could be bouncing from room to room and then sit down and do a telemedicine consult. I mean, I certainly could actually, but in terms of ease of scheduling for my team, my scribe, my technicians, I almost feel like I'd want to carve out a section of my day, call it an hour. Maybe it's the last hour of the day where, that's my telemedicine hour. And I'm doing, second opinions, or, I'm doing, different evaluations or counseling. I think that would be a good way to do this sort of in a private practice setting. I do think that for private practice folks, you got to put it front and center on your website. Do you want to do a telemedicine visit and have them have access to sign up to that, over the internet, in order to kind of do that. And if you do that, I think you could build this up pretty easily.
Yeah.
And that's exactly how it works, Blake. Our experience with this is very clear. It's not a good idea to mix telemedicine because they are completely different flows. You need to isolate some time in your day or in your week and dedicate completely to telemedicine, because you need to set up the stuff, be comfortable, and then it's just very quickly, it flows. But if you need to jump from this to a different way of seeing patients, it's not very smooth. So that's a good call.
Yeah, so these are some of the lessons learned that we've learned the hard way, and that is exactly it. If I could put this at the top of the list, which I should probably move it to the top of the list, I should designate telehealth only clinics, do not mix. And not stress that enough. I mean, you're right. It's a completely different way of thinking and dealing with patients. So I've set aside an entire day just for telehealth visits like this. And again, these are, typically time-based visits, unless I'm using the video slit lamp, which we'll get to in a second, where I can bill an I-code. But for the regular visits, these are time-based visits. Patients want to sit there and talk, and you want to review their records. And, they normally, and they're coming to you for a second opinion because they've seen 7 other doctors, and these patients require time. And so when you can bill on a time-based method, then you should set aside enough time for you to get comfortable and really talk to them and give them their money's worth. And then that being said, imagine the cost savings of a patient just paying a flat fee or a level 5, new patient consult fee versus flying to see you and taking time off work and getting a hotel room and all the other travel arrangements that need to be made. This is a very big benefit for the patients as well. So what do y'all think about this list of lessons learned? Anything you would add here or take away? Some of it's Epic specific, so just
I think the biggest thing that people overlook is your second point there: engage office staff. Because when this first got started, man, my team was acting like this is the most difficult thing ever to get patients on the books for telemedicine. I'm like, listen, Roger's been doing this for a decade, for God's sakes. If he can do it, we can do this stuff. Come on. And so what I quickly realized is that you have to, especially when booking patients for telemedicine and giving them the option, you have to be careful with the words that your phone team is using. For us, our patients, or we kind of went in because at first there wasn't a lot of uptick to telemedicine. Patients are saying, no, don't worry about it. I have an appointment, in 3 days, but, since everything's canceled and everybody's closed down, I'm just not going to come in. And so our staff kind of changed to say, listen, instead of saying, hey, we'd like to offer you the chance to do this telemedicine, they changed their words to, hey, Dr. Williamson asked that I call you. You have an appointment tomorrow at 2 p.m. He'd like to keep that appointment with you, and you can do that from the safety of your own home, right? So just by that simple, word switch, patients were much more likely to say, okay, I can do that. So I think you have to, just like any other system change or technology integration, you got to motivate your team, educate and motivate.
I think the other thing is having a staff member who is the champion or like the go-to person, the person who really embraces it, learns everything about it, makes sure that they're really comfortable, and then talks positively about it to the other staff members. And so if you can find somebody that really is positive and uplifting and answers questions for others, I think that's a huge benefit.
Definitely. Roger, how do you guys word this when you're talking to your patients? Because Blake, I love the way you put that, and just that little switch really does make a difference. We learned that today. So.
You know what we are trying today? We are trying to avoid the way the word telemedicine, because at some point has been like cannibalized a little bit. So in order to differentiate a little bit, we are using more modular consultation, and we always speak about doing the examination stage, the first phase, where we are going to examine deeply your eyes, and then we'll have the private session with the best doctor that suits your case. So we are speaking about customizing even the two modules. So because it's a unique opportunity where we have all the exams that we can analyze with time. And for example, you have a 21-year-old boy that goes and performs a topography, and then you realize, and he was thinking that he was a candidate for LASIK, and he was directed to the refractive department. But then you realize that he should go directly to the cornea specialist because he's not a good candidate for LASIK, and he has a keratoconus, and he jumps directly. So you are avoiding the time for them, and you're just allocating directly to the best resource for him.
I love this part of how Roger approaches it, and the fact that he uses the hybrid, the actual technology part of the visit to triage the doctor. Like we never think of medicine that way, that we're triaging them to the appropriate doctor after their testing. And I think that's awesome.
Yeah, I think that's great, which is actually a really good segue to hybrid televisits. And these have been very popular. This is when, just for people who don't know, I know you guys all know, this is when the patient comes in for testing and then you talk to them afterwards. So whether it's later in the day, whether it's video or a phone call, doesn't matter, but it's a segmented visit, just like Roger was saying. So a modular visit. This has been a lifesaver for us because we've had our patients come in, but they come in just for a short time for expedited testing. We tell them that they're okay to go home, and then we'll follow up with them later for the discussion portion. So it's been keeping our patients less exposed, potentially exposed, keeping our staff less exposed as well. But the really nice benefit of this, and the reason this is going to stick around, is because now we've figured out that we can bring patients into their preferred locations. So for people who have multiple offices, patients can come to any of your locations to have their testing done, and then you can follow up with them from wherever you are. And then the other nice thing about it is that they don't have to wait for your clinic day to come in. They can come any day and get their testing and then follow up with you. So
doctors are not anymore, they are not anymore the bottleneck. That's the point.
We're not the rate limiting factor anymore. It's like a hospital without walls now, where they can even be seen after hours and on the weekends too. We're going to weigh in on this here in a little bit, but I wanted to play the news interview that was done recently with a patient who we were doing a hybrid visit with. So you guys can watch this and then we'll discuss.
Focusing on you, innovations in modern medicine. From your team of eye experts at Bascom Palmer Eye Institute.
I can
see that very well there.
A new age in eye care has arrived at Bascom Palmer Eye Institute, the nation's #1 eye hospital. Now, doctors are treating patients through a combination of virtual and in-person visits.
This is super advanced, creative telemedicine. It allows Bascom Palmer specialists to help patients from anywhere in the world.
Dr. Ranya Habash is part of the medical team for 12-year-old Chloe Shapiro. After performing her recent eye surgery, Dr. Habash remotely observed Chloe's clinic checkup by using a video slit lamp.
So it snaps into place just on a smartphone. You start the Zoom call, you do a screen share, and the person on the other end can watch the entire exam.
In just one sitting, Chloe consulted with 2 of her doctors.
That's why I also like this whole telehealth, like the online appointments, because it's very useful in that sense. Like in 3 hours, I got 2 appointments done.
Patients like Chloe can also use Bascom Palmer's virtual urgent care and second opinion virtual consults, all without leaving the comfort of their own homes.
Telemedicine has been super useful for us during difficult times like this. It's also an opportunity for us to grow the practice of medicine in a more evolved way. So I'm really proud of Bascom Palmer for that.
Okay, so let's
I have to say, that's the first, when I saw that video, that was the first time I ever thought, in terms of like actually seeing the slit lamp exam and all that stuff like Roger does, I was like, wait, I can do that. I mean, it's as easy as snapping on your iPhone and hitting a Zoom call and doing screen share. It was like light bulb. Finally, I wasn't intimidated. I was like, wait, I can do that, so that's so cool.
Yeah, it's low technology really for such a great image. I mean, cameras on phones are so wonderful now that, this really is accessible. So I think she was an amazing patient and very well spoken for a young girl.
Did you also KP on that endothelium? You can actually see it with the video slit lamp there. So you're right.
You see, guys, have you realized that there has been a huge intersection in all this crisis, in this pandemic, where all the communication that have in a way exploded with all the Zooms and webinars, and at the same point, all these lessons learned have been very, very fast spread among all the ophthalmologists with accessibility, with telemedicine at the same time. It has been like a bomb, but everything together. If this pandemic had happened 10 years ago, telemedicine was only isolated by 2 or 3 centers. Today, as you are showing, you can just have with the iPhone, you just put it, you adjust it to your slit lamp, you're there in 2 minutes. So everything has been like very aligned.
Ranya, what do you use what's the device you use to couple your iPhone to the slit lamp?
Well, there are many, many different brands. We do have a very precise slit lamp prepared for our suite, for our immersive telemedicine suite, where we are mimicking the same from one side to the other with the same dimensions. Well, Blake has been there. It's very unique. But reality is that that's not the only way to do telemedicine. And today you can do telemedicine in a modular way, like you're showing, in a real way, in an active way with a cell phone. There are many adapters. There are ones performed by a company in Germany that is very good, run by a Colombian guy. But mainly what you are comfortable. Whatever you have a good image with your cell phone, you will be able to use it in real time.
Yeah, the one we're using is by Digital Eye Center. I have no financial interest in it whatsoever, but it was like $250 for that adapter. And
exactly.
It's great because it's universal, fits any smartphone or any tablet, and I can take it with me anywhere I am or leave it. I've sent them to all our campuses so that they're there for everyone. Every floor in our building has them. The ER has some so that the residents can do it after hours and do staffing with their senior residents and with the attendings. So it's been very handy for us. But I think that what you said, Roger, is perfect. This is the new age of medicine. So we are, on the cutting edge of things here. And kind of like I said in my video, it's been an opportunity for us to evolve the practice of medicine further. And you can see there, I've, been able to consult with another physician there, be able to see the exam from no matter where I was. And that's a huge benefit to patients these days. Blake, what are your final thoughts on things here?
Well, I think that what you did with that phone kind of makes me think like, how can I? First of all, different people are going to accept that in different ways, and they're going to be able to integrate it into what they do in different ways. For me personally, what I see that being a huge benefit for is like, what if I'm on vacation, right? What if I want to take a week off, but I don't want to see zero patients, and then because then you always make up for it when you get back to work that following week. So if I can actually see some of my cataract evals or LASIK evals or some stuff like that, and actually look at them through a slit lamp through what you did, to me that's an opportunity to not feel quite as guilty when I take some time off and not quite have such a backlog of patients.
Well, thank you all, Blake, Roger, Kathy. Thank you so much for being with us today, and for this like really open, nice discussion about telehealth and kind of the future of telehealth and the next generation of it. I welcome questions from our audience so that we can go through those. I'm sure there's going to be a lot of them. So thank you all for joining us, and stay tuned for us answering the questions too. Thanks a lot, BMC.
Thank you.
Thanks, Ranya.
All right. Well, hope everyone enjoyed that. We have a few questions that have come in, and we've been kind of tossing around some topics that came up as well. I think people are really intrigued by our show and tell method. And that's important because a lot of people are sort of scared away from telemedicine, and they listen to all these webinars and they hear all this stuff being said, but then until you actually try it or see one being done, you can't really imagine what it's going to be like and how simple it really can be. So I love the fact that we're pulling in our colleagues and showing them what we're doing with our exams. I mean, I've certainly done that at Bascom, for some of our colleagues who've been a little bit, more hesitant to jump in. I've found reasons almost to invite them in to do a second opinion consult or another, give me a little backup on a patient. And it's amazing how when they jump in, they really get the hang of things. Have you guys noticed that as well?
Yeah, I think getting started with telemedicine is just like getting started with cataract surgery. No one goes to do their first cataract and anticipates doing the entire thing start to finish, unless you're Kathy McCabe, of course. But maybe you just make your incisions, or maybe you're just putting the lens in, right? So similarly, maybe just pick like one patient and do like a PA, or someone's has a red eye issue, and you say, you know what, let me just do this before you come in, just to kind of see. Or maybe just pick one, post-op that you could do. Don't try to, create an entire list of telemed patients on day one, and just that little bit at a time, you're going to start to notice, oh, you know what, this is something I can do.
Or maybe even just triaging your ER patients. It's an easy, no-brainer place to start, because certainly we know if we see somebody who has a subconjunctival hemorrhage, we don't necessarily need to see that patient, and it's something readily seen on a telehealth visit. So if we could save even just those patients from coming in, that would be really nice for everybody involved, right? So that's a simple place. But I think the way that you did it, Ranya, where you had, your consultation collaboration with other physicians, if we're bringing physicians into those visits through telehealth collaboratively, that's kind of a nice bridge to say, look, here's how I talk to the patient, here's how I'm getting you involved. And maybe that's a nice bridge too for some of our colleagues who are a little bit unsure of how to go through the steps, and how do you really interact with the patient in these visits. So I think that's a great place to start as well.
Yeah, Blake, that's analogous to jumping in and doing your first cataract surgery without the attending there.
You don't want to do that. None of us do.
And Kathy, you're so right. Those tiny little visits that we think nothing of, and we get tons of pictures of subconj hemorrhages and chalasia in our inboxes all the time. Those are such powerful telemedicine visits, actually, because think about this. You have a patient there who would have come into the ER, but instead, in 30 seconds, you told them that they just need to stay home and use artificial tears. Or a patient with a sty, who has 3 kids at home and can't really take time off work to come see you. That is so important to a patient, and we think nothing of it. I think we've become so numb to the types of services that we're giving our patients that we forget what a big service we're providing. And another thing along these same lines, when we did our virtual urgent care, we actually found during the pandemic that we had 70% of patients that we could actually treat without bringing them in. And they all had these tiny little things going on, like conjunctivitis or subconch hemorrhage or chalasia or whatever, that we didn't need to bring them in for. And the other 30% that we did need to bring in were patients who really needed to come in. And so we expedited their treatment instead. And those are patients, who called in, and we did a video call, and they would say, I have new flashes and floaters. They started yesterday. They're getting worse, whatever. So obviously you need to come in. And those were our statistics, our rough statistics, which I found really interesting, actually.
You know what? In this conversation, it just reminds me of so many times that we have family members or friends, and we all have this, who send you a picture, usually when you're on vacation or wherever, and say, look at my eye. What should I do about my eye? Do I need to go in? Do I need to take my child into the doctor today on the weekend? Is this something that can wait? And telehealth is no different than all of those kinds of consultations we've done with family and friends for years. And so I think it's just another bridge that we actually did get to do it with a wider population, not just our family and friends, and we actually get to bill for it. So we've all done that to some extent. It should be at least a little bit familiar.
Yeah, definitely. It's amazing to actually, get paid for for the work you do, right? Okay, so along those same lines, I thought it was really interesting. Collaborative care kept coming up as a very big topic for people. And I think this is interesting because there's been such a turnaround in medicine lately with the consumerization of medicine. So patients want their medical records, and they want interoperability, and they want more of a say in their medical care. And I think that's great. But this type of thing really lends itself to that atmosphere, because now you're having patients sort of take control of their visits. They're using, e-check-in, and they're getting apps, and they're more engaged in their visits and that sort of thing. So I find that this again is just the new evolution of medicine. Would you all agree with that?
Yeah, I think the other thing that it allows is for patients to decide, not just who's available to drive them to their visit, but who in their family do they want to know about their care and help them with their care, because they can actually bring whoever it is in their environment into the visit at their desire to have them there very easily, in a way that may not be as accessible to them if they have to tell them, take 2 or 3 or 4 hours out of your day and come to my visit with me. So I think even in that regard of being better educated and deciding how they want to be educated and who they want to be educated along with them, they get control of that. So yeah, I think there's many ways that this puts them more in control of their visit.
Yeah, I never thought about that. It's so true, though. I feel like at least once or twice a week, there's an older gentleman who I start to have my cataract conversation with, and he says, "Hang on, Dr. Williamson, my wife's not here, or my daughter's not here, whatever nice gal is taking care of the guy, and we have to reschedule. And in COVID, that's not something that you want to do." And patients are scared to do that. So what a great way to sort of bring someone in. I haven't done that yet, but that's my pearl that I've learned from this webinar.
I do that every opportunity I get, because it takes 2 seconds to do. It's so easy, but it's such a high impact thing for the patient. And they get so tickled that their family member is on, and the family members love it. It's talked about widely in all our patient our patient satisfaction scores and comments. They always comment about that. So that's a really good pearl to take from this.
And that's something that we've done already. How many times do you mind if I just call my son, who's an ophthalmologist, across the country, and have them on speakerphone during the visit? So we've kind of already done those things. We're just going to do it in a more intentional, deliberate, and effective way. So I think
and in video instead of just phone. Okay, I think that we are wrapping up at this point. Any final thoughts from the two of you?
I just think the world's changing, and this is one of the ways that it's changing, that in the end, as providers, it's going to be a better way of providing better care for our patients. And as a patient, I feel like, having the opportunity to have my family members available to collaborate with other specialists in a problem that I have, I think it's powerful for me as a patient too. So I hope that we take this opportunity to really develop it and make it meaningful effective, and just easier and more accessible to patients and providers in the future.
Yeah, and I'd say, for those of you who are watching this who have done zero telemedicine, or maybe you did it during shutdown and you've kind of eased back and you're trying to get back into it, again, just baby steps. Just try to pick one patient, look at your schedule tomorrow, and just go through and try to find someone who you think may be, a red eye or something like that, and just pick that one patient and give it a shot. And I think that by doing that, you're going to get more and more comfortable, and you can implement this in many different ways and find a lot of efficiencies in your practice, as I have. So this isn't something that is cumbersome or slows you down. This is something that speeds you up if you learn to sort of hack it to fit your practice patterns.
Yeah, very well said. Thank you so much. And thanks to BMC for having us here and for putting this program together. It is so important that we all stay connected and help each other through this and beyond. So I'm really thrilled about that. We've had so many developments lately in our field, and we should be really proud of it. And this kind of opens up the floodgates for us to explore some of these other things coming down the road. Like now, the ability to have autonomous diagnostics. There was an FDA approval recently for INOC, which will allow diabetic retinopathy autonomous reads to be reimbursed by CMS. And there's a new code for that, which is 92229. So a lot of artificial intelligence and machine learning stuff coming out. Inject Sense is around the corner as well. That's an implantable device with continuous IOP monitoring. That's another version of remote home monitoring, or that is remote home monitoring. Again, another reimbursable visit. So those are really important things that are out on the horizon now. And I think telemedicine is the gateway to all of that. So kudos to you guys for embracing this so quickly and bringing us into the future of medicine. It's been great having you both here. And Roger too.
And thank you so much for helping educate us, Ranya, and for all of you helping me to become better at this as well. So I appreciate it.
Thanks for your leadership, Ranya. Appreciate it.
No, we've all been learning from each other. That's the point of all of this, to share best practices. And hopefully now we can all, keep communicating after this. Thank you again.
Thank you for tuning in to our program today. We'd also like to thank Drs. Habash, McCabe, Williamson, and Zaldivar for their participation in today's program. This program was supported with advertising by Novartis Pharmaceuticals Corporation. The opinions and views expressed during this program were those of the individual participants and were not necessarily those of Novartis Pharmaceuticals Corporation or its affiliates. This content will be available for on-demand listening as an episode of CRST, the podcast.